Thank you, Stephen. We can go ahead and go to the first slide. So my PQI was on chemotherapy-induced nausea and vomiting. As many of us know, this is one of the most debilitating toxicities that we see with chemotherapy. There are several guidelines that are available, including NCCN, ASCO, the European Society of Medical Oncology, as well as the MASS guidelines that help clinicians and guide them into selecting and optimizing anti-nausea medications for patients. And then we've seen over the past couple of years how we've seen new NK1s come to market, new 5-HT3s and combination products. So the purpose of this PQI was ultimately to help clinicians optimize therapies and know how to which patients would be more appropriate for what therapies. So as a general overview, chemotherapy-induced nausea and vomiting is oftentimes classified as having low, moderate to severe risk, with low being around 10% incidence, moderate is about 10 to 30, and high can be anywhere up to 90%. Oftentimes, these may be patients that are receiving agents such as cisplatin. And then there are several factors that also help you prognosticate which patients will have or will be at more risk for CIMV, such as age, sex, history of alcohol consumption, whether or not they're going to be receiving chemotherapy with radiation, and also the anatomical location of their tumors. We can go on to the next slide, Stephen. This slide here, or this part of the PQI, demonstrates the most common agents and the various classes that we see in CIMV. So most commonly, most of us will use 5-HT3s and NK1s, as well as the benzodiazepines such as lorazepam for anticipatory nausea vomiting. We'll see glucocorticoids, most commonly used as dexamethasone, as well as some of the dopaminergic agents and some of the combination agents that combine the NK1 and 5-HT3 antagonists. Next slide, please. So when you have a patient who often presents with high hematogenic potential, the most common practice is to administer an NK1 antagonist in combination with a 5-HT3. Oftentimes, these patients are also candidates for steroids plus or minus olanzapine. Olanzapine has been shown to significantly reduce CIMV, and there's quite a bit of data behind it. For moderate hematogenistic potential, oftentimes these patients can be controlled without an NK1 antagonist, so the 5-HT3s plus steroids. And low hematogenicity, they may be able to use single agent therapies. And in some patients, in a select few, they actually may be able to tolerate chemotherapy without any pre-medication. It's important that when we're initiating these therapies that patients, that we evaluate drug-drug interactions, especially in the elderly populations or patients that may be receiving agents such as dexamethasone and Emend IV or fosaprepitant. There are dosage modifications there. And in the elderly, you want to be careful with your benzodiazepines and your dopaminergic agents because those oftentimes will require dosage modifications to avoid excess toxicities. And then we also want to make sure that for our patients that their antiemetics, their home regimen is optimized, and these patients have their therapies from prior to, with cycle 1. You don't want these patients having to deal with nausea and vomiting after they've received their chemotherapy and having to make a trip to the pharmacy to get their antiemetics. So it's often an important counseling point. We can go on to the next slide, Stephen. So some select patient-centered activities. When educating patients, sometimes it's useful to provide maybe a handout or some type of visual aid that can help patients, especially in the ones that may be receiving a long-acting 5-HT3, and they are also having Zofran or ondansetron as a take-home, because it's important to keep in mind the duration, and then Zofran is unlikely to act during the duration of the other agent. It's also important to prioritize and sequence therapies. So whether your standard is using Zofran as first line and potentially Compazine as second line, or vice versa, but it's important that patients understand how to sequence and prioritize these therapies. And then it's also important to have patients verbalize back the plan that pharmacists come up with patients to ensure that they have a solid understanding. Also with CIMV, it's important to counsel patients to drink plenty of fluids just to make sure that they stay hydrated, and to also counsel them on some of the side effects associated with some of these agents. We can go to the next slide. And here are the references, but Stephen, go to the skip 2, please, for the supplemental material. So we also provided in this PQI some supplemental material for clinicians that demonstrates select regimens and how you can combine these regimens to prevent CINV. So we did include high emetic potential as well as moderate and low potential, and how select regimens could be combined, as well as some of the combination products. And with that, I will take any questions if anyone in the audience has a question.
Thanks, KIROLLOS. And I just want to point out that the PQI as well as the supplemental information is available for everyone to view on the NCODA website at www.ncoda.org/PQI. So we will open it up. But KIROLLOS, I'd like to start things off by asking you, what are some of the main takeaways from the PQI that you would tell a colleague or someone who's in a position?
Stephen, you're kind of cutting out on me, but I think the ultimate question was, what's the ultimate takeaway? Really, as we've seen in the past year to 2 years, we've seen a lot of combination products. So their place in therapy is becoming more and more important. How do we utilize these agents? There are select agents that we can use if there are certain fluid shortages, so how we can optimize these therapies. And there are also some agents that do not have drug-drug interactions with dexamethasone, et cetera, et cetera. So it's really important for clinicians to understand how to utilize them to optimize patient safety and as well as control the CINV.
Great, KIROLLOS. Thank you. And as I mentioned, we will open it up for some questions. So if anyone has any questions, feel free to utilize the chat, the Q&A box, and we'll gladly take a look. And so it looks like we do have one question, KIROLLOS. Our member asked us, Propellant have less drug interactions, or Rolapitin have less drug interactions?
So the question is does Rolapitin have less drug interactions? Is that the question?
That's correct.
So there is some certain information about Rolapitin, and there was recent FDA warnings about Varubi per se. Drug-drug interactions, there aren't as many drug-drug interactions with Varubi. You do not need to dose adjust the dexamethasone as you with fosaprepitant. However, I would be cautious when using Rolapitin, simply because of the new FDA safety warnings that there has been associated with anaphylactic reactions. So it's kind of important to keep in mind in a select group of patients, because the post-marketing data of Rolapitin showed more hypersensitivity to reactions than the initial, I think than what was initially anticipated.
Great, KIROLLOS. Well, thank you. And if anyone should have any additional questions, we can save those for the end as well. But for now, we're going to move on to our next section. So again, KIROLLOS, thank you so much.